Hello friends, my name is Santosh Abraham. I'm working as a specialist registrar in Scarborough General Hospital. Today I would like to present about congenital adrenal hyperplasia due to 21 hydroxylase deficiency based on the Endocrine Society guidelines. So this is an extensive topic, and I would like to remind you that this presentation might take a long time, so probably I will first give you an introduction to CAH and something about genetics and other few details, and then we will go to guidelines. And when I review the guidelines, I will add extra points because to make slides for each point is quite difficult. So I'm trying to make it as concise as possible. So please bear with me. So CAH is a group of autosomal recessive disorders characterized by impaired cortisol synthesis. So it's autosomal recessive, it has got impaired cortisol synthesis. So worldwide incidence is between 1:14,000 and 1:18,000. It is more prevalent in genetically isolated groups like Alaskan Yupiks, etc. So in 95% of the cases, this is very important, 95% of cases, mutations in CYP2A12 is the most important. So this is the enzyme which converts 17-hydroxyprogesterone to 11-deoxycortisol and progesterone to deoxycorticosterone. So mutations in CYP2 and A2, which is responsible for the gene encoding the 21-hydroxylase. So 21-hydroxylase converts 17-hydroxyprogesterone to deoxycortisol and progesterone to deoxycorticosterone. So there will be a deficiency of deoxycortisol. So when this gene is deficient, when the enzyme is deficient, you have these products such as 17-OHP and the progesterone being converted to sex hormones, mainly androgens. So blockage of cortisol synthesis leads to corticotropin stimulation of the adrenal cortex, because there is no cortisol. So there will be enhanced ACTH stimulation of the cortex, adrenal cortex. So again, it results in the accumulation of cortisol precursors, and these will be diverted to the sex hormone biosynthesis. So cardinal feature in newborn females is abnormal development of external genitalia with variable extent of virilization. So this happens in classic or severe virilizing CAH. So there is abnormal development of external genitalia and variable extent of virilization. So if you have bilateral non-palpable gonads in an infant, CAH evaluation should be done. So in 75% of cases with severe enzyme deficiency, that's the classic CAH, inadequate aldosterone production will be present. So it leads to salt wasting, failure to thrive, fatal hypovolemia and shock. So that's why we do this neonatal or newborn screening for the CAH, because otherwise it could give rise to these complications, because in 75% of the cases you have inadequate aldosterone and it causes salt wasting, failure to thrive and shock. So misdiagnosis of salt-losing CAH is associated with increased risk for early neonatal morbidity and mortality. So this underpins the importance of screening for CAH at birth. So if the simple virilizing CAH is not recognized, these kids may undergo rapid postnatal growth and virilization. In addition to this classic salt wasting and simple virilizing forms, there is a mild or non-classic form, the NCCAH, which has variable degrees of postnatal androgen excess, but is sometimes or usually asymptomatic. So it's very important to remember that this in the NCCAH there is no Addisonian crisis. So they might not develop adrenal insufficiency. So the non-classic forms of CAH and the NCAH have a prevalence of 1:500 to 1,000 in general white population, but in consanguineous marriages the prevalence increases to 1:50 to 1:100. So NCCAH has an overall frequency of 1:200 in the US population. The severity correlates with the CYP21A2 allelic variation. So the severity of the NCCAH correlates with the CYP21A2 allelic variation. About almost 300 CYP2A12 mutations are known, but large deletions and splicing mutation as shown here, intron 2 IVS13, cytosine to guanine. So this ablate the enzyme activities. So this mutation actually comprises 50% of classic CAH alleles. So this constitutes about 50% of the classic CAH, this above mutation. In approximately 1% to 2%, a substitution in exon 4 is associated with simple virilizing classic CH. So simple virilizing classic CH, exon 4 amino acid substitution, and point mutation in exon 7 is responsible for the NCAH allele. So it preserves 20 to 50% of the enzyme. So that's why it produces the NCCH. So exon 7 NCCH, exon 4 simple virilizing classic CH. Because many compound heterozygous patients carry more than one mutation on either or both CYP21A2 alleles, there is a wide spectrum of phenotypes. So patients can present in different ways with CAH. So what about prenatal treatment? Prenatal treatment with DEX aims to reduce female genital virilization and its associated risk of social stigma, the need for reconstructive surgery, and the emotional stress associated with the birth of a child with atypical sexual development. Although these points will be again covered in the guidelines, I'm emphasizing these points. So that is why we aim for the prenatal treatment, especially for the female fetuses. It is inappropriate for male fetuses because this form of CH does not disrupt the development of male genitalia. Prenatal treatment does not change the need for lifelong hormone replacement therapy, and also the medical monitoring, and also the risk of life-threatening salt losing crisis if therapy is interrupted. So even if you treat prenatally, lifelong hormone replacement therapy and medical monitoring should be in place. So when will you treat a female fetus prenatally who is having an increased risk of CAH? So ideally the fetal genitalia becomes virilized after 6 weeks of conception. So treatment should be started 6 to 7 weeks. But CVS, that is chorionic villus biopsy, cannot be performed until 10 to 12 weeks. All pregnancies suspected to have CAH would need to be treated. Specialized laboratories can perform sex determination of the fetal Y chromosome in the maternal blood with 99% accuracy. So this could improve the probability of treating an affected female fetus from 1.8 to 1.4. So if you do the fetal Y chromosome DNA assay, it could increase the probability of treating an affected female fetus from 1.8 to 1.4. So that means twice the chance of an affected female getting treated. So prenatal diagnosis and treatment research should not be performed in countries where female infanticide is prevalent. So that needs to be taken into account for the prenatal treatment. So cortisol, in contrast to cortisol and prednisolone, dexamethasone is not inactivated by placental 11 beta HSD2, and so it reaches the fetus. So dexamethasone is preferred for prenatal treatment. So almost all the protocols employ prenatal treatment using dexamethasone at dose of 20 mg per kilogram pre-pregnancy maternal body weight to a maximum of 1.5 gram per day. So why we use the dex? Because it's not inactivated by placental 11 beta HSD2, and so it reaches the fetus. And also antenatal betamethasone can improve the pulmonary outcome in preterm infants, but are associated with decreased newborn weight, length, head circumference. Also, newborns prenatally treated with dex for potential CAH have normal birth weight, but nevertheless they weigh 400 grams less than the control. So that's why they could have a low birth weight. So what is the importance of this low birth weight? The reduced birth weight increases adult risk for chronic disorders like hypertension, type 2 diabetes, and cardiovascular risk. So fetal exposure to dexamethasone could potentially have a prenatal programming. That's what it's called. So it could result in modification of the genes encoding the intima of aorta, and and thus it could lead to hypertension and cardiovascular disease, or it could result in receptor related changes or molecular changes even. So antenatal dex also is known as an independent risk factor for the development of asthma. So this was given for the gestational pulmonary maturation, but those individuals later were found to have asthma. Also, who have received antenatal betamethasone, those children have displayed, after 30 years, they have displayed insulin resistance, and 7% had elevated basal cortisol also. So those are the risks with the antenatal glucocorticoid treatments. So altered DNA methylation apparently underlies the long-term effects of both glucocorticoids and maternal stress on the fetus. So let's come to the prenatal treatment of CAH. Again, there are no specific protocols recommended. Prenatal therapy is still considered as experimental. So in pregnant women at risk of carrying a fetus affected with CAH, obtain prenatal therapy only through protocols approved by the institutional review boards. So these research protocols for prenatal therapy should include genetic screening for Y chromosome, Y, to exclude male fetuses from potential treatment groups. So coming to the diagnosis of CAH. So in infants with positive newborn screens for CAH, they recommend referral to pediatric endocrinologists and also evaluation by congenital stimulation as needed. So in symptomatic individuals after infancy, like in adults, we recommend screening with an early morning baseline serum 17 OHP by liquid chromatography, tandem mass spectrometry, so LC TM method, with borderline 17 hydroxyprogesterone levels, a complete adrenocortical profile after a cosintropin test to differentiate between 21 hydroxylase deficiency and other defects has to be done. So in people with CAH, genotyping is suggested only when the results of adrenocortical profile after a cosintropin stimulation test are equivocal, or the cosintropin cannot be performed in an accurate way. So that's only when you do the genotyping. Otherwise, you try to get the diagnosis with the cosintropin test. So in the treatment of classic congenital adrenal hyperplasia, the treatment of classic CAH, they recommend maintenance therapy with hydrocortisone, and in growing individuals, there is no evidence to support the use of oral hydrocortisone suspension and also long-acting potent glucocorticoids. And in newborns and in early infancy, fludrocortisone and sodium chloride supplements to the regimen can be used. So what is the importance of treating classic congenital adrenal hyperplasia? So proper treatment with the glucocorticoids prevents adrenal crisis and virilization, allowing nearly normal growth and development during childhood. So it's a difficult balance between hyperandrogenism and hypercortisolism. So the recommended glucocorticoid doses to reduce markedly elevated adrenal hormones may be exceeded, but it is important to rapidly reduce the dose when the target levels are achieved. So frequent assessments are needed, and don't try to completely normalize the 17 OHP levels, because it results in the overtreatment and the person could develop features of Cushing syndrome. And infants with classic 21 hydroxylase deficiency requires glucocorticoids in addition to mineral corticoid treatment and supplemental sodium chloride. And in salt wasting CAH, this amount will increase. And also this mineral corticoid requirement should be reassessed based on blood pressure, serum sodium, potassium, and plasma renin activity. So clinically, the defect in aldosterone biosynthesis is seen only in the salt wasting form, but subclinical aldosterone deficiency is present in all forms of 21 hydroxylase deficiency. So all individuals with classic CAH benefit from fluorocortisone therapy and adequate dietary sodium beginning in infancy. So this is essential for euvolemia and for reducing vasopressin and ACTH. So it allows reduced glucocorticoid dosing and it leads to better growth. And during childhood, glucocorticoid preferred is hydrocortisone because it has got short half-life and it minimizes the adverse side effects. So it has got minimal adverse side effects due to short half-life, because more potent glucocorticoids will produce more growth suppression. And due to uneven distribution in the liquid form, oral suspensions are not recommended. Prednisolone and dexamethasone are effective in suppressing adrenal androgens in children with CAH, but these are more likely to impede statural growth, so they are not recommended. So the adult height of patients with congenital adrenal hyperplasia correlates negatively with the dose of the glucocorticoid administered in early puberty. So this is very important. Patients treated with less than 20 microgram of hydrocortisone per meter square per day at the start of puberty are significantly taller than those with higher HC doses. So it is important during puberty to treat with the lowest effective dose to achieve treatment goals and also to achieve the optimal height. And also fluorocortisone, the need for mineral corticoids decreases with age as serum aldosterone is high and the renal mineral corticoid receptor is the mRNA is low at birth, and salt content also in most diets is high. So as the person grows, the fluorocortisone requirement will become less, and most non-hypertensive adults will benefit from this fluorocortisone replacement. How about the hyperandrogenic symptoms in young women? They might require androgen receptor antagonists. So oral contraceptives containing drospirenone may effectively reduce both adrenal and ovarian androgen synthesis. And they don't affect cortisol, blood pressure, or potassium levels. But these oral contraceptives cannot replace the glucocorticoids and mineralocorticoids. And spironolactone is contraindicated because it is an androgen antagonist. Even though it's an androgen antagonist, it is also a mineralocorticoid antagonist and causes volume depletion. So in adults with classical CAH, treat with daily hydrocortisone or long-acting glucocorticoids plus mineralocorticoids. In individuals with classic CAH, always monitor for signs of glucocorticoid excess as well as signs of inadequate androgen normalization to optimize the adrenal steroid profile. So it is that balance between these two that needs to be taken care. So also in individuals with classic CAH, monitor for signs of mineralocorticoid deficiency and excess. So stress dosing. In situations such as febrile illness, gastroenteritis with dehydration, major surgery, and major trauma, the glucocorticoid dose has to be increased. But under everyday mental and emotional stress and minor illnesses, or before routine physical exercise, there is no recommendation to use the increased dose. In other words, you don't need to use the increased dosage for everyday mental stresses and minor illnesses, etc. So this stress dosing is given every 6 hours. And when stress doses of hydrocortisone are administered, mineralocorticoids are not needed because the hydrocortisone can activate mineralocorticoid receptors. So there is a risk of hypoglycemia and electrolyte imbalance. So these patients should be given oral glucose and electrolyte supplementation, especially in young children. So if they cannot tolerate oral fluids, parenteral administration of the glucocorticoids and isotonic fluids to prevent adrenal crisis should be done. So sometimes the injections may not be available. So these patients should be supplied with vials of injectable hydrocortisone and should be taught to self-administer the drug IM intramuscularly if there is any emergency. And also they are advised to carry a medical alert brace. So all they are advised to wear or carry a medical identification or a medical alert brace indicating that they have adrenal insufficiency. And also the guidelines do recommend educating patients and their guardians and close contacts on adrenal crisis prevention and increasing the dose of glucocorticoid, but not mineralocorticoid during intercurrent illness. And also an glucocorticoid injection kit for emergency use, and providing education on parenteral self-administration or lay administration as needed. So monitoring therapy in children less than 18 months, close monitoring in the first 3 months of life, and then every 3 months thereafter. After 1.5 years or 18 months, evaluation every 4 months. So from 3 months after 1.5 years to every 4 months. So growth velocity, weight, blood pressure has to be regularly assessed, and also physical examinations plus biochemical measurements to look for the adequacy of glucocorticoid and mineralocorticoid. Also under the age of 2 years, they advise annual bone age assessment until near adult height is attained. So adjusting medications for CAH is difficult. So the challenge is to find the appropriate fludrocortisone dose without causing any hypertension, as mineralocorticoid sensitivity naturally increases in the first year of life. So in the medical history, you have to ask about the age of pubic hair onset, any unexpected body growth or growth of the phallus, any development of adult apocrine odor, and any symptoms of salt craving or adrenal crisis. You should also look for any accelerated height velocity, any signs of virilization, any advanced bone maturation. So bone age is a lagging indicator of the past inadequate adrenal suppression and should therefore be used judiciously. Bone age X-rays are not helpful before the age of 2 years. Excessive radiation exposure should be avoided. If the bone age advances to a pubertal level at an inappropriately early age, testing for secondary, central, or GnRH dependent precocious puberty is warranted. So, if the bone age is rapidly advancing, so you need to look for the secondary, central, or GnRH dependent precocious puberty. And a word about TARTs. These are testicular adrenal rest tumors. So it increases after 10 years of age. So screening by testicular ultrasound assessments should begin in adolescence. So optimization of glucocorticoid treatment can shrink early TARTs and prevent progressive enlargement, resulting in infertility. So in adults, they do recommend annual physical examinations, blood pressure, BMI, and look for Cushingoid features, and also biochemical measurements to assess the adequacy of glucocorticoid and mineralocorticoid replacement. And also monitoring treatment through consistently timed hormone measurements. Do not completely suppress endogenous adrenal steroid secretion to prevent adverse effects of over-treatment. That's very important. So endogenous adrenal steroid secretion should not be completely suppressed. And for women, androstenedione and testosterone are good parameters of disease control. So in ladies who have a delay in conception, glucocorticoid treatment should aim to achieve a follicular phase progesterone level less than 0.6 nanogram per ml, a much tighter control than for women not attempting to conceive, often requiring a bedtime dose of prednisolone. And in men, suppressed gonadotrophins are a reliable sign of infertility. And elevated FSH indicates sustained testicular damage in men with TARTs. Also, men with TARTs may have, that is the testicular adrenal rest tumor, will have low morning testosterone, indicating poor Leydig function. So, if the ratio of androstenedione to testosterone is more than 2, it indicates poor CAH control with a significant fraction of testosterone coming from the adrenals. So the ratio of androstenedione to testosterone in normal individuals in eugonadal men is less than 0.5. So if it's more than 5, it indicates poor CAH control. So a treatment of non-classical adrenal hyperplasia in children and adolescents with inappropriately early onset and rapid progression of puberty or bone age, and in adolescent patients with overt virilization, glucocorticoid replacement should be done. So in symptomatic children and adolescents with rapid progression of puberty and rapid mineralization of the bone or rapid growth of the bone, and also with overt virilization. So these risks and benefits should be discussed with the patient's family. In asymptomatic non-pregnant individuals with NCCEH, no glucocorticoid treatment is recommended. In previously treated patients with NCCEH, the treatment could be discontinued if adult height is attained or symptoms resolve. So in adult women with NCCH who have hyperandrogenism or infertility, glucocorticoid treatment is suggested. In most adults, it is not needed. But in exceptions in most adult males, it's not needed. But exception in adult males include infertility, testicular adrenal rest tumors or TARTs, or adrenal tumors, or intermediate phenotypes between the classic and the non-classic phenotypes. So hydrocortisone stress dosing for major surgery, trauma or childbirth is needed only if the patient has got suboptimal cortisol response to cosintropin or if there is iatrogenic adrenal suppression. So hydrocortisone stress dosing is needed only when there is suboptimal cortisol response or iatrogenic adrenal suppression. So long-term management of patients with CAH. So transition to adult care begins several years prior to dismissal of the pediatric, prior to getting out from the pediatric endocrinologist. In adolescent females, a thorough gynecological history and examination to ensure functional female anatomy without stenosis or abnormalities in menstruation should be done. So professionals, doctors familiar with congenital adrenal hyperplasia should provide genetic counseling in children with CAH or transitioning adults or adults with NCCH, and also partners of patients with CAH who are planning to become pregnant. Also, in people with CAH who have impaired fertility, an endocrinology referral, that is a reproductive endocrinology referral, is suggested. So management of congenital adrenal hyperplasia and NCCH during pregnancy. So who are infertile or have a history of prior miscarriage, treat with a glucocorticoid that does not transverse the placenta, because that's important, because it has to protect the developing fetus. So who are pregnant, an endocrinology referral has to be done, preferably to an endocrinologist who treats the CAH. So those who become pregnant continue the pre-pregnancy dose of hydrocortisone or prednisolone and fludrocortisone, and with dosage adjustments if symptoms and signs of glucocorticoid insufficiency occur. So androgen and cortisol levels gradually increase during pregnancy due to increase in the SHBG, that is the sex hormone binding globulin, and the corticosteroid binding globulin, the CBG. Usually the placental aromatization typically protects the fetus from potential virilizing effects of the maternal androgens. So maternal 17-hydroxyprogesterone is elevated in normal pregnancy, and so it cannot be used to monitor the glucocorticoid treatment. So high progesterone levels during pregnancy may compete for the mineralocorticoid receptor, so there might be an increased need for the fludrocortisone dose. The clinicians should not use DEX or other steroids that are not inactivated by placental beta HSD2 to treat pregnancy. So non-specific symptoms of adrenal insufficiency, including postural hypertension, fatigue, may develop in pregnancy. In such cases, the glucocorticoid dosage may be increased from 20% to 40% from the 24th week onwards. Regarding a non-classic form, it is difficult to draw definite conclusions about the need for glucocorticoid therapy. However, treatment may benefit infertile women with NCCH or with a history of miscarriage. And in women with CAH, usually cesarean section is the most common method of delivery. This is due to increased prevalence of previous vaginal surgery and cephalopelvic disproportion. But in some cases, vaginal delivery has also been proposed. So try to avoid dexamethasone, or do not use dexamethasone as it transverses the placenta, and because it cannot be inactivated by the placenta. So surveillance of long-term complications of CAH and its treatment. This include counseling regarding healthy lifestyles such as to maintain a good BMI and to avoid metabolic syndrome and the sequelae. In adults, screening of bone mineral density in anyone subjected to a prolonged period of higher than average glucocorticoid dosing, or also who has suffered a non-traumatic fracture, has to be considered. So bone mineral density for a prolonged period of higher than normal glucocorticoid therapy, or who has undergone a non-traumatic fracture. So this lifestyle lifestyle counseling is very important, because children with CAH have a higher BMI. So half of the pediatric patients are overweight. So individuals with CAH may have higher frequency of hypertension, hyperlipidemia, atrial fibrillation, venous thromboembolism, obesity, and diabetes. So that's why we are always focusing on improving the lifestyle choices at an early age. So in this view of increasing the increased tendency to have body fat and increased potential for cardiac and metabolic consequences, they suggest lifestyle changes beginning from an early age. So in women, the most significant metabolic abnormality was the prevalence of gestational diabetes. So it was higher than the prevalence for general population. Also, routine adrenal imaging is not recommended. Reserve adrenal imaging for individuals with CAH who have evidence of an adrenal mass, or who have poor disease control, or lapse in treatment of several years, or a lack of response to the therapy. So it is done usually when you have suspicion of an adrenal mass, or the disease is poorly controlled, and there is no lack of there is no response to therapy, or there's a lapse in the treatment. So they recommend periodic testicular ultrasound to assess for the development of testicular adrenal rest tumor in males. Why? Because adrenal masses affect 1 to 4% of normal men and women, and the prevalence increases with age. So one study even showed adults with CAH had a high prevalence of benign adrenal masses, especially those on inadequate glucocorticoid therapy. So sorry, that's why it's they don't recommend routine adrenal imaging, but in periodic testicular ultrasound has to be done in males who are developing who are at risk of developing testicular adrenal rest tumors. And routine evaluation of cardiac and metabolic disease beyond that recommended for general population is not advised. So periodic testicular ultrasound has to be done in males with classic CAH, but there is no need to do an evaluation more than what's done for the general population in case of cardiac and metabolic disease. So restoring functional anatomy by surgery in individuals. This is a low-key topic, so that's why I have I have made it a very condensed slide. So in patients with CAH, especially in pediatric people with very less virilization, they should be given the parents should be given information about surgical options, including delaying surgery or observation until the child is older. So it should be done with experienced pediatric surgeons or urologists, pediatric endocrinologists, pediatric anesthesiologists. So it should be done in those centers. So extensive discussions regarding risks and benefits should be done, and it's a shared decision making. So it is usually addressed in an MDT meeting, and the potential complications has to be reviewed. So in severely virilized females, usually the surgery is done to repair the urogenital sinus. So if a minor is to be treated, the decisions remain the prerogative of families, that is parents and even the older children, they can also assent. So it's a joint decision actually. So in female patients with whom surgery is chosen, vaginoplasty using urogenital mobilization, and when chosen, neurovascular sparing clitoroplasty for severe clitoromegaly is done. So vaginoplasty using urogenital mobilization is a surgery of choice. So experimental therapies and future directions. In patients with congenital adrenal hyperplasia, they advise against using experimental treatment approaches outside the formally approved clinical trials. Also, they don't advocate bilateral adrenalectomy. So experimental therapy, a few words about experimental therapy. The androgen estrogen antagonists are combined with glucocorticoid, or the synthesis inhibitors. The androgen synthesis inhibitors are combined with the glucocorticoid. So in the first study, there was a 4-drug regimen that combined androgen antagonist flutamide with aromatase inhibitor testosterone. So it resulted in reduced dosage of hydrocortisone and fludrocortisone. So this regimen resulted in decreased growth rate, weight velocity, and bone maturation. Another trial has been done with abiraterone acetate, which is a potent inhibitor of P450C17, and it's indicated for castration-resistant prostate cancer. So this was actually studied in 6 adult women. So it normalized the predose androstenedione on day 7 in all participants. So its use, but however, may be limited to prepubertal children and to adults taking gonadal replacement, because this study was limited to adult women taking oral contraceptives. Other areas are growth hormone and growth promoting drugs. About these you could read more. An alternative strategy to decrease adrenal androgen excess is to reduce the ACTH production. So another study was done to using a selective corticotropin releasing hormone receptor type 1 antagonist. It's called NBI 77860. So it reduced the mean morning increase in ACTH by more than 40%, and the 17-hydroxyprogesterone concentration was decreased to 27%. Another study was done using mitotane in a person with classic CAH and TART. So adrenal derived androgen precursors declined, the sperm count increased, and paternity was achieved. But due to the toxicity, it could not be recommended outside the approved research. Another drug is ATR 101. It shares some mechanism of mitotane. It is under the phase 1 trial now. And why don't we recommend adrenalectomy? Because even though it reduces the risk of virilization in females and allows for decreased glucocorticoid dosing, it increases the risk of adrenal crisis due to the loss of residual adrenal function. So, and the possible loss of hormones that may have beneficial effects. So, and also it may not remove the hyperandrogenemia owing to the potential development of adrenal breast tumors in the testes. So of all these combined, for all these reasons, and owing to the high risk for significant morbidity and mortality after operation, it is not actually advised. Finally, there has been some research going on with gene therapy. So in mice, it has temporarily restored adrenal steroidogenesis. So the ability to correct genetic mutations causing CAH by applying gene therapy on an individual's own adrenal stem cells would theoretically cure CAH and avoid the need for adrenal replacement therapy. So cell-based therapies and gene editing technology may present novel options for disease remediation or cure in the future. So I know that these guidelines are very extensive and this was a very huge topic, but this is an important topic for the FCE exam, so you need to know a few points about this, and there will be questions based on pathology, pathophysiology, management of congenital adrenal hyperplasia. So, and also you need to know how to distinguish between CAH and NCH clinically and biochemically. Thank you.